Good morning, I'm Shannon Switkowski. I'm the clinic coordinator for Cardi-OH. I want to draw your attention to our registration. Call is open for spring 2021, and we have the same series, Tackling Type 2 Diabetes, backed by popular demand. You could register online. Please share this with your colleagues. It's important to get this out there, and your testimony would be great if you could share how great the series was. We would appreciate that. So we'll go around and introduce our speakers today. Is Liz Beverly?
Good morning, I'm Liz Beverly. I'm from Ohio University Heritage College of Osteopathic Medicine, and I'm a behavioral diabetes researcher.
Thank you. Gautam Rao.
Good morning, everyone. I'm Gautam Rao. I'm the chair of Family Medicine and Community Health at Case Western, and I'm also the director of Cardi-OH.
Good morning. And Dr. Duncan.
Hi there, I'm Kathleen Duncan, endocrinologist at Ohio State University.
And you can take it away.
All right, so we have our final echo clinic. This is our template as usual. We'll have a didactic. This time it's going to be a little bit of a potpourri based on your feedback, and also some really interesting and useful elements on diabetes and use of language. That'll be followed by our case study presentation and wrap up. Don't forget to complete your post-clinic survey. It's very important for our ongoing planning and evaluation. And these are our disclosures. Those were sent to you previously by email. So we'll start off this, this didactic portion with Dr. Elizabeth Beverly, who's going to discuss the importance of language in diabetes. This is really a critical element in kind of building trust with our patients, performing really skilled shared decision-making, and providing overall good clinical care. So Dr. Beverly?
Thank you, Dr. Duncan. So I'm actually really excited to talk about this topic. It's something that I've become very passionate about over the past few years. So today's objectives, when we're going to talk about the importance of language, I'm going to describe type 2 diabetes stigma. And part of describing that is also describing stigma as it relates to type 1 diabetes. I'm going to list and describe the 5, this is American Diabetes Association, and then what was formerly the American Association of Diabetes Educators, recommendations for language in diabetes care. And then hopefully at the end of this, you'll be able to list a minimum of 3 suggestions for recommended terminology in diabetes language. So thinking about diabetes stigma, what is it? Most of us are familiar with stigma, what it means, but in the context of diabetes, it's considering the role that self-care plays. So thinking about all the self-care behaviors that a person with diabetes, and this is any type of diabetes, thinking about everything that a person has to do in a given day. It's reasonable to think about how we might think that certain attributes could be associated with diabetes such that we might have stigma for how they develop their diabetes. So because of the influence of diet as well as physical activity in managing diabetes, people might read into those things and attribute those to why they have diabetes in the first place. So the definition of diabetes stigma is it's referring to negative feelings such as exclusion, rejection, and blame associated with having diabetes. The most common form of diabetes stigma, and that's been documented in the literature, and this is regardless of any type of diabetes that you have, is the perception that people with diabetes are responsible for developing their own diabetes. Next slide, please. So there was a study, this is about 3 years ago now, and it was published in Clinical Diabetes. It's very interesting, and it had over 5,000 adults, and it found that about 3/4 of people with type 1 diabetes and half of people with type 2 felt that they experienced stigma from their own diabetes. And the people who reported higher rates of stigma for, specifically to their diabetes tended to be people who had a BMI greater than 25, those who had an A1C greater than 7, those who also reported blood glucose levels. So this is when they tested, they had blood glucose levels above target. And then those who also self-reported depression. And then they also observed that people who had a greater insulin therapy regimen also tended to report higher rates of stigma related to their diabetes. And this is something that we can discuss towards the end of this. Next slide, please. So thinking about all of this, and then there have been a lot of qualitative studies, and I actually did one of these qualitative studies, that there's a lot in the literature that shows that providers, family members, and friends, and then even those in training, so health professionals in training, there are a lot of negative attributions that people will, when they're talking about diabetes, may use certain adjectives or adverbs describing people who have diabetes without even maybe realizing it. And some of those that I've picked up from these articles when describing or referring to a person with diabetes are terms like weak or lazy, gluttons, disgusting, poor, bad, and not terribly intelligent. And so you can think about this, that if you were to ever read one of those articles and you saw a quotation from a healthcare professional or a family member with one of those words in it, how that would be very disappointing, but also very disheartening. So what the research has shown now, and this is research building on, I would say, for the past, the past decade, is that people who report more stigma specific to their diabetes are also reporting higher levels of psychological distress. And that would make sense, right? So they're reporting more depressive symptoms, they report less social support, and lower quality of life. And we had an excellent didactic a couple of weeks ago about some of the psychosocial issues with diabetes. And we also know that people who have higher depressive symptoms, and this can also be with anxiety, but who report less social support, lower quality of life, those psychosocial issues are also associated with fewer self-care behaviors, higher A1C levels, and then increased complications. So it's this negative cycle. So if someone perceives stigma, they're going to have higher psychological distress. And then people with higher psychological distress will perform fewer self-care behaviors. Fewer self-care behaviors in turn might result in higher blood glucose levels. If that's over a long period of time, that will be a higher A1C, and that could lead to increased complications. And you can see here, there are a number of studies that have documented this. Next slide, please. So this comes me to the main point of this, which is our recommended language. So this is actually led internationally, this charge about changing our language that we, in regards to how we speak about diabetes. And the individual who led this change is Dr. Jane Spate out of Australia. So about 10 years ago, Diabetes Australia was the first to do something about this. And then 4 years later, you had the International Diabetes Federation, and then the United States caught on a little bit slower. So you see, we finally adapted some language recommendations in 2017. That was the American Diabetes Association and the American Association of Diabetes Educators. Next slide, please. So what Jane Spate and the person who led the charge in the United States was actually another Jane, Dr. Jane Dickinson. So the two Janes, as I like to refer to it, what they did is showing that research of stigma and psychological distress and how the negative impact of stigma it has on diabetes. They came forward with, let's come up with language recommendations that are patient-centered or person-centered, and things that are strengths-based. So I'm going to go over what the American Diabetes Association and American Association of Diabetes Educators recommend. So they have 5 recommendations. So for the first recommendation, it's language that's neutral, non-judgmental, based on facts, actions, physiology, and biology. So an example of that is, and I'm going to tell you that when I did my training for diabetes, I used all of these terms. So it's been a work in progress for me to practice to not say these things. I was trained to say glycemic control. I was trained to say good or poor. So it's something that I've had to practice, and I catch myself when I'm talking, about this. So, don't be too hard on yourself. It's something that you have to practice using this new terminology. So an example of something that would be considered judgmental would be if you said good or poor control for diabetes. What they're suggesting is, instead of saying anything about control, just say manage. And anytime you're referring to numbers, whether it's blood glucose or A1C, just say numbers or A1C. Just, matter of fact, just state it as that. The second recommendation is use language that's free from stigma. So I think this one has been going around for much longer than the past 10 years about how we should stay away from compliance as a term. So removing compliance, there's actually a movement to get rid of the word adherence as well. Instead of saying compliance or adherence, we should use the term engagement and involvement. And it's also really hard. Well, how could you say medication adherence? Well, what they're saying in terms of that is just taking medication or medication taking. And then the other one is a lot of times, particularly with type 2, we think, people might say, well, it's a lifestyle disease because so much of it is related to self-care behaviors. But we also know there's so many other factors, and we have experts here today who can talk about the genetics and so many of the other factors that come into play with type 2 diabetes, that it's just better to say it's diabetes. The third language recommendation is use language that's strengths-based, respectful, inclusive, and imparts hope. So some examples of words to take away would be prevent. So a lot of times, this is something that I learned is, if you do these self-care behaviors, you can prevent complications. Well, it turns out you can do everything perfectly, but you can still over time develop a complication despite your best efforts. And that's because it's a chronic progressive condition. So it's much more accurate to say you can reduce your risk of developing a complication. And then it would also lead to less self-blame later down the road. Refused. So just changing the way you would frame something, like a person won't refuse something, they might just decline something that you suggest. Fourth recommendation is use language that fosters collaboration between patients and providers. Again, everything is about shared decision-making and putting it person-centered. So regimen, I have found, is the hardest word for me to remove from my vocabulary. I'm very used to saying regimen. And instead, what they're asking is say plan or choice. And then anytime this is talking to someone, instead of saying you can or can't do something, just say, would you like to consider? And it leaves it very open-ended, and it's very empowering to the person. And then the final recommendation is use language that's person-centered. So most of us are familiar with this. We've been using this the entire didactic series. Instead of saying diabetic, you would say a person with diabetes. And then rather than saying like, what did you do for your diabetes? You could say, how about you tell me about your self-care? It's much more open-ended, and it allows the person to then explain what they've done to help take care of themselves. Next slide, please. So there are some important considerations in talking about this. It's not as simple as, oh, just follow these recommendations. People are diverse. So that also means that for what applies for one person might not work for everyone. And I say this because I actually have several very close friends in the type 1 diabetes world. And there's a movement online that's the Identity First movement. And what this is saying is, even though we're focusing on person first and person-centered language here with diabetes, there is another movement online. This is mainly online, and this is mainly with people with type 1, that's identity first. And that's saying that diabetes is part of their identity, and they want to identify as a person with diabetes. And this is also a movement that you see in the disability literature. And so they want to identify with their disability, or they want to identify with their diabetes. So some people might actually want to be called a diabetic. So what this means is you can't necessarily know what everyone wants to be referred to or what terms they want to use in their conversation. So you can't always predict what somebody might prefer in terms of how they are referred to in terms of their diabetes. Next slide. So if I was to summarize this information, these are the terms I would say we have to really work hard to remove from the way we talk about diabetes. Diabetic, even though I just talked about the identity first, what I would say with that is you can ask somebody, how would you like me to talk about your diabetes? And if somebody says, you can call me a diabetic, then you would know. Otherwise, the safest thing is to say a person with diabetes. Another one that wasn't mentioned in the language recommendations from a person who has to check their blood glucose levels is we used to say test. That's how I was trained when I first started. And when I was at Joslin, the Joslin Diabetes Center, one of the things that I had to work really hard at doing is they are very steadfast in saying, no, we monitor our blood glucose levels because a test implies that you could fail something. And that can be very judgmental. And it also goes against, people don't fail at their diabetes. So that's something that I had to work hard to remove that word. Control, instead of saying control, say manage. Unrealistic goals. Instead of saying unrealistic goals, you could say that someone has high expectations for self-management. Removing language like they're suffering from their diabetes, people are living with their diabetes. Any of the judgmental language, if it's good or poor or bad, it's just their targets or it's their numbers. And then removing compliance and adherence, talking about engaging or taking meds. Next slide. So the takeaways from this, you know, ask the person that you're working with what they prefer in terms of language. But if you don't know, playing it safe is to always go with person first language. Okay, I think that's the last slide. All right, so I'm going to pass the baton to Dr. Dungan and Dr. Rao.
Great, thank you, Liz. I just pause here and just echo that this is a very learning process for myself. I'm sure for many of you, if I went back to my slide or from my clinic notes from 5 years ago, I would probably be appalled. But you know, it's always something I think a learning process in how we incorporate these the language. Anyway, so the next portion of our didactic is going to address some of the feedback that we have received thus far after our last session. Thank you all for completing those surveys. And there were, you know, maybe a couple of themes that we thought were useful and like to pull out here separately. And so the first of these themes is just a little bit more guidance on the specifics of lipid management in persons with diabetes. So a number of you may be familiar with the AHA, you know, ACC guidelines. So I just wanted to briefly review the ADA guidelines as well. I think they're slightly different, but the spirit of the recommendations are pretty much the same. The next slide. So here's our objectives. List primary prevention indications for statins with different cardiovascular risk. We're going to list indications for SGLT2 or GLP-1 receptors in patients who have nephropathy. This was the second kind of element that came out of the feedback that you all shared with us. It was basically, you know, what do we do with patients who have advanced complications? And then third was just to provide a little bit of an overview on identifying and managing microvascular disease. This is far beyond the scope of our discussion today to really go into a lot of detail, but just to provide that framework for you. So in terms of lipid management, I think most people would agree that some type of risk calculation is really important. And we should use a risk calculator like the ACC, AHA risk calculator, but also keep in mind that there are some nuances in persons with diabetes that the risk calculator does not account for. For example, the duration of diabetes or complications, particularly nephropathy, which greatly increases your risk of cardiovascular disease. One should first, as always, consider any kind of lifestyle modifications that might be necessary. And these are some specific call outs from the ADA, and I think make a lot of sense in terms of diet, weight loss, where appropriate, reduction in your trans-saturated fats, increased physical activity. What may not be always widely appreciated is in those patients who have hypertriglyceridemia with an example, the case that was discussed last week, they can be exquisitely sensitive to glycemic, to glucose levels. So they have high glucose levels, and see, I even have the word control in there. When you control those glucose levels, oftentimes triglycerides will come down depending on what type of hypertriglyceride they have. And then monitoring strategies recommended at least at diagnosis and every 5 years. I think that's probably not a lot of new news to you, and just after change in therapy. And annually in patients who are on medications. Now in the guidelines, really, you know, we think about, okay, well, we're really not even aiming for a target. We're looking at risk-based measures as a first line strategy. But I think the importance of doing that is to monitor whether they are actually taking the medications. Next slide. So this is just an overview of the risk-based approach that is advocated by the ADA. And I think, again, you'll see that it's fairly similar to the ACC. Basically, if you're less than 40 years old and you have additional risk factors, then you might consider a statin. And that risk factor based approach could be based on their cardiovascular, cardiac risk score. And if they have, if they still have an LDL cholesterol that you know what, I think this might have. Yeah, so if they are a cardiac risk of greater than 20%, you might and then add additional therapies as needed to a maximally tolerated dose of statin. And then if they're greater than 40 years old, it's pretty much a statin across the board. That can be a tough pill to swallow. I'm sure as many of you have come to appreciate, and trying to convince somebody who doesn't have an elevated cholesterol level that they still need a statin to lower their cholesterol levels. But perhaps maybe reframing that to, it's not just to lower your cholesterol levels, but to lower the risk of cardiovascular disease. And then if their risk is even higher, then you can consider LDL reduction down to 70 using maximally tolerated statin plus perhaps ezetimibe or PCSK9 inhibitor. And the other couple of things that I'll point out is that this is also dependent upon a number of other risk factors that are not included in that risk score. Again, albuminuria or CKD are big factors. And in longstanding diabetes also is a very important risk factor, although we don't always know how long a person has had diabetes, especially if it's type 2 diabetes. And if someone is greater than 75 years of age, it really what's recommended is to consider statin after shared decision making. So consider all the risk factors. There's no specific guidance just because there's a limitation in literature. Next slide. So for hypertriglyceridemia, it's very common in persons who have diabetes. In general, if the fasting glucose is over 500, it's recommended first look for secondary causes because often they are there. And then if needed, and there's no reversible secondary causes, then you can add fibrate or a prescription strength fish oil is preferred, and to a statin if they're already on a statin. Now, if they have cardiovascular disease or multiple risk factors, then that's really when you should consider adding icosapent ethyl, which is Vascepa. So that's based on the Reduce It trial, which ironically did not demonstrate that the triglyceride lowering efficacy of the drug itself was responsible for the reduction in cardiovascular events, but it is likely specific to the fact that EPA probably has some cardiovascular effects that are beneficial over and above the EPA plus DHA combinations. Next slide. So I'm not going to go over this. I just provide this as a reference for you. And in fact, this is a summary of the actual table that appears in the standards of care from 2020. And you can see that it is quite intense. This is really just the components of a comprehensive medical evaluation at the initial visit versus follow-up and annual. And I think you'll agree with me that it's probably impossible to do all of these at any one visit. But it is, and it really just sort of illustrates how complex it can be to manage all aspects of health in a person who has diabetes. So again, I'm not going to go over this in detail, but it provides kind of a framework for that. Next slide. Okay, so now I've got just a slide for each type of microvascular complications as a brief overview. So for neuropathy, screening, as you know, begins annually at the time of diagnosis, and it should include a history of symptoms plus temperature or pinprick to really assess the small fibers, or and vibration sense, which is to assess the large fibers. Now, the 10-gram monofilament is actually to assess risk for foot ulcers or amputation. So that's really something separate. So in an ideal world, you'd have all three of those elements. And recognizing that neuropathy can be asymptomatic. So even if someone has no symptoms whatsoever, if they have an abnormal exam, that's the rationale behind that. And it is a diagnosis of exclusion. So you might consider other etiologies, B12 deficiency, so forth. I have readily available foot care precautions that I share, particularly those patients who have a high risk foot and who have a reduced 10-gram monofilament. And then our therapies, as a reminder, FDA approved is pregabalin and duloxetine, although gabapentin is also widely used, as you know. There are a few other agents, but not, these are generally not first-line agents. Next slide. Nephropathy screening, again, begins at the time of diagnosis for persons with type 2 diabetes, includes the urine albumin to creatinine plus EGFR, and repeating testing to confirm. So that's the one thing that sometimes I think trips us up, is giving someone a diagnosis of proteinuria or microalbuminuria if they have just a single elevated urine albumin. And if the EGFR is greater than 30, it's recommended, in addition to, well, first of all, they should have an ACE inhibitor or ARB in place if they have proteinuria. But if the EGFR is greater than 30 and they have evidence of nephropathy, especially proteinuria, it is now grade A level evidence to use an SGLT2 inhibitor. And a GLP-1 receptor agonist could be considered as well. There are some studies that have kind of renal function as a hard endpoint or a composite measure of renal function. In those long-term cardiovascular outcomes trials, they are a secondary endpoint, and there are as of now, no dedicated renal outcomes trials for GLP-1s. However, there is some suggestion that there is a modest effect on renal outcomes, in large parts due to reduction in albuminuria, but as a secondary measure, also potentially reduction in a doubling of creatinine in end-stage renal disease. Blood pressure targets, according to the ADA, in persons who have nephropathy, 140/90, but considering 130/80, particularly in those at highest cardiovascular risk, they do not specify how that gets teased out, because persons, again, with nephropathy are at very high cardiovascular risk. Dietary protein is really the recommended daily allowance for those who are not on dialysis, and also considering higher intake in those who are on dialysis due to catabolic effects of end-stage renal disease. And then referring to a nephrologist if the EGFR is less than 30, or there's some uncertainty in etiology, there's rapid progression, things like that. Next slide. In terms of retinopathy, recommending A1C, blood pressure, lipids, all three of them are really important for reduction in the risk and severity and progression of retinopathy. And retinopathy is probably the most exquisitely sensitive to A1C reductions. Dilated eye exam recommended, again, at diagnosis, and every 1 to 2 years if there's no diabetic retinopathy, and annually if so. And the one thing that is easy to forget as patients are diagnosed at a younger age is during pregnancy. So we should be referring patients before they get pregnant, ideally, but then also the first trimester of pregnancy and every trimester, as there is a risk of progression of retinopathy during pregnancy. And then just a quick overview of the types of therapies. These are well beyond the scope of this talk. For proliferative retinopathy, generally it's high risk. I'm sorry, so for high risk proliferative retinopathy and some severe non-proliferative diabetic retinopathy, it's pan-photocoagulation, and intravitreous EGFR is used for proliferative diabetic retinopathy, and in particular, central macular edema. Okay, so then if we have, maybe just a minute, Gautam, I wonder if you wanted to discuss the one last point that we had, and I think this has come up earlier in the lecture series as well, is the cost effectiveness of diabetes medications. Do you want to add a couple of thoughts on that?
Sure. So thank you, Kathleen. So I think the first thing to discuss is make sure we're on the same page as far as cost effectiveness goes, because there's a lot of misunderstandings about what that means. People often misinterpret it as cost or cost benefit. So cost effectiveness is a comparison between two therapies with respect to a certain outcome. So the early cost effectiveness studies of statins, for example, compared statin treatment to no statin treatment and looked at the rate of cardiovascular events. And as you can imagine, this is going back 20 years ago, statins were very cost effective. In those days, it was $10,000 to $15,000 to prevent one cardiovascular outcome. So some of the treatments that Kathleen has talked to you about are very, very expensive. And that's usually when the issue of cost effectiveness comes up. And the comparison is usually not no treatment. So we would not say you're going to be on insulin and metformin, and we might add a GLP-1 or add an SGLT2, and we're trying to prevent a cardiovascular event. But nobody would compare SGLT2s or GLP-1s to no treatment with respect to that. So in my brief assessment, and I know I've only got a minute or so, I will say this to you, and I'm sorry, there's a helicopter here, but SGLT2s and GLP-1s are proven to be cost effective in preventing cardiovascular events among patients with diabetes. That's the bottom line. Kathleen and I actually went back and forth by email looking at lipid lowering treatments as well, because that's a hot button issue. For primary or secondary prevention of cardiovascular events, statin drugs are cost effective by a long shot. And the outcomes we do, in other words, what we put on the denominator, it's usually quality adjusted life year or a cardiovascular event. It doesn't really matter. Where we get into controversy is the PCSK9 inhibitors, which Repatha is one, for example. And these are extremely expensive. The actual cost of each of those medications is about $15,000 per year. So just the absolute cost of it. And so are they cost effective? It turns out they are not cost effective unless someone has established severe heart disease. Now, the other question that commonly comes up is, well, I mean, is cost the only thing we care about? It is in the sense that the cost effectiveness, in other words, the cost per event for a PCSK9 is more than $500,000. And you say, well, that's a lot of money, but it might be worth it. Well, given that resources are finite, we could spend that $500,000 in some other way, whether it's diabetic education, whether it's something, it's cardiac rehab, or it's statin drugs, or smoking cessation, that would be more cost effective. So it's a balance in terms of how we look at society. I'm going to stop there. I think Leonard had a question. Let me see what it is. I think this question is actually for Kathleen before we go on. It's about using statins in people over age 75. Can you repeat what you said?
Yes, so in the ADA guidelines, if you have a patient who is over the age of 75, there's no specific guidance. I will tell you from my perspective, age isn't always the best determinant of health, and I would probably think about what's their life expectancy and their overall cardiovascular risk. And so you do a shared decision making approach. Well, we don't have great evidence because there weren't a lot of people who were over the age of 75 in all of these clinical trials. But if they're otherwise, you have a decent life expectancy, then I would still use a statin. And if they're already on a statin before the age of 75, I would still continue it.
Thanks, Kathleen. So I just wanted to summarize what I just said, just in closing. So SGLT2s, GLP-1s, obviously statins, all cost effective, make use of them as indicated according to the guidelines that Kathleen has talked about. PCSK9s, be much more cautious. So they're generally reserved for people who are at very, very high risk, usually for secondary prevention, people who have established heart disease already. Thanks.
Great. And we have another comment in the chat. Feel free, if you have comments or questions, turn your video on and share those with us. And you could also share them in the chat box. This one's from Adam Przinski. In my own work, we found that traditional cardiovascular risk factors are effectively unrelated to cardiovascular outcomes in the oldest age groups. Okay, thank you for that, Adam. I didn't know if you wanted to, did you want to elaborate on that? Why that might be?
I think he's off.
Okay.
He was on. I just searched for him. I don't see him right now.
He had to leave early.
Okay, great. All right. So throughout this this ECHO series, has anyone had additional feedback on use of language in their own care? Have you made any changes to the way that you use diabetes language? So Liz, I really think your comment about how persons view having diabetes in terms of being a diabetic or not a diabetic is interesting, because I do have patients who call themselves I'm a diabetic, and so in that situation, we are not in a position of saying, well, okay, no, try to correct them. I think that's what I'm hearing you say.
Yeah, so what I would say is what I've observed is the movement towards identity first is mainly in type 1. So anecdotally, first of all, I'm not clinical. So this is all coming from the research experience and then also my friends who have diabetes. Most people with type 2 prefer the person first language or person-centered language. People with type 1, I would say, the T1D exchange, if anyone's familiar with, it's the largest registry with people with type 1. They volunteer to be a part of that research. The type 1, so the T1D exchange has done some polling with the people. It's over 20,000 people with type 1, and it's about 50-50. So about 50% are okay with being called diabetic, and about 50% prefer to not be called that. And a lot of that, when they were asked why, some were just saying, oh, I just, whatever, I don't care. So it's not, because they've had it for so long, they have been called so many different things. And so I think that they are okay going forward with it. It's very individual. Just like, think about it in terms of, I have some friends who are on this call right now. Karen Bailey's a diabetes educator. There could be a word that, she would be indifferent to, whereas if somebody says something to me that I could take that very personal and be very sensitive to me. We all have our triggers. And so it's just something that I think this is really important that we're focusing on now in terms of diabetes. I know it's one more thing for you guys to think about as clinicians. But if you just think about it in the context of we're all humans and language affects us too, I think that it's something small and simple that you guys we can all do. I do it in the way that I write, and I make sure whenever I talk to people that I try to use the best language possible.
This is Sharon, and I would say an analogy that might help you think about it a little better is, would you ever call a person with epilepsy an epileptic? I wouldn't, because I can't pronounce it. But it just sounds derogatory when you think that way, right? So the same applies for people with diabetes.
This is Karen. I mean, over the years working with people with diabetes, what has really struck me is just how difficult it is when you have diabetes to manage your care, especially if you're on multiple doses of insulin and you have to do calculations, and then there's the diet part. And so what I found is that, really showing some respect for those people right off the bat when they come into the visit, and really showing them that I really think what they are able to do is great. And it's a challenge, and most people don't have to worry about what you're worrying about. So good for you and what you're able to do. And I think once they feel a little more empowered, then it makes them feel like they can they can do more. But in the environment around us, when we go to our homes and around other people, I think a lot of times what we get is finger pointing and should you be eating that? And did you take your insulin today? Have you checked your blood sugar? So the language that surrounds us usually as people with diabetes can be kind of negative and accusatory. And I think as professionals that understand, we can provide that support and hopefully change the language in the general community over time.
Mm-hmm. Yeah, and it goes for the, our staff too. When I see kind of the way, maybe our nurses or, the schedulers, kind of all across the board, I think that speaks to the whole kind of general population. And Mary Lee says in the comments, I like to use tell me about your diabetes, especially when new patients, because it starts off interaction very open-ended, and discuss what's important to them. Yeah. Okay.
Hey, Liz, I just had a question for you as well. I mean, the identity aspect of type 1 diabetes, is that because, and this is my experience, and I don't have a lot of experience with type 1 diabetes, and if I do, it's all with kids. But did they see themselves as almost a community? It seems like they share recipes and monitors and strategies and what to do at school. And often the adolescents I have, their best friends are also children or adolescents with type 1 diabetes. So that seems like a completely different dynamic. Is that what's at play here compared to type 2 diabetes?
That's a really interesting question that I think somebody could make into a research project. I think the type 1 diabetes online community is one of the most powerful communities that have organized for a positive mission for health. This is thousands of members whose sole mission is to support each other and be there for each other. And I agree, all of my friends who have type 1, most of their other friends have type 1 and they've met online and they call each other their best friends. So, and I think of it is, unless you have type 1, you don't know what it's like. It must be incredibly hard to live with type 1 diabetes. And perhaps it's part of that online community where they have made the decision to move forward with Identity First. I know that it has originated out of some of those online forums. So I don't know if it's a handful of individuals who have adopted some of the disability, it's the disability scholars work for Identity First, and perhaps it's some of those type 1 individuals who have taken on that scholarship. I'm not sure. That would be a really interesting thing to look at, how that originated with type 1.
Okay, I would like to shift gears now to our case. Could we bring that up here? Thank you for that. That's a really great case. And I guess my first question is, he is retired. Do we know, has he tried to go through any of the programs from through pharmaceutical companies? In some cases, their income is too high to qualify for those programs. Is that the case here?
I'm not sure if he's went through that process, but I know a lot of them, yeah, that's where we run into problems with Medicaid in this gap, but I'm not sure if he's actually looked into any of the pharmacy assistant. That's a good point. And I do see in the chat, he is not a veteran. So we do chart on that, unfortunately. Yep.
Yeah, Emily Vronto says many companies have changed their requirements, especially during the pandemic, for patients' assistance medications. Yeah, and then Mary Lee Clemens says, depending on income, he may qualify for SGLT2 or GLP-1 assistance. Yeah. And they're often generous for patients who don't have insurance, but over the Medicaid income level. Yeah, that's, I think, really going to be the key for him. I think there's a good chance, since unless he's got like a huge bank account for some reason that he acquired as a welder, but yeah. Okay, so Chris Taylor mentions, with his willingness to test and the external motivators to walk, He is likely to see solid changes in his glucose if he can increase walking, could be a gateway to impactive lifestyle changes. You know, I don't know if you want to comment more on that, Chris, but, you know, I think what's really important to remind patients also is that even if they're not seeing weight loss, you still can see really substantial changes in glucose control with regular activity. And so, you know, there are multiple reasons that, you know, if they don't see the scale change.
Yeah, because it becomes a non-insulin requiring way to lower blood glucose with just the physical movement and the muscle contraction helps clear blood glucose. And it might be one of those things, if he's got a family member living with him and he's got other family members that are kind of encouraging him, it also means he probably wouldn't have to do it alone. And I think even if he builds up some of the strength, I noticed the neuropathy and some of those areas, but he does have a 2-story. So if he has the ability to kind of start walking, he'll start to see those changes. And as Dr. Dungan said, even if he's not losing weight, he'll start to see the impact on his blood glucose. Then that becomes that positive feedback loop that what I'm doing is actually working. And then he can you can start the conversation around that seafood diet. You see it, I eat it. Kind of focus, but at least it becomes, you start with one, make it successful, and then the next one can help contribute to the next set of goals.
Thank you. Yeah, the chat is great. A lot of great suggestions. If he's a veteran, sometimes they don't know that they have those kind of benefits. Do you have a 340B at your clinic or no? Okay. Yeah.
We do have a registered dietitian. So actually one of our third-year medical students was a dietitian prior to going to medical school, and she's actually volunteering her time and doing individualized patients with visits. So that's a great idea. I don't think I've connected them yet. So that's perfect.
Mm-hmm. Yeah, and is it injections that bothers him, or is it insulin?
That's another great question. It wasn't, I assumed it was the injection, but
yeah, there's a comment on maybe using a low dose DPP4, but you could also use an oral, GLP-1 now, if you can get it through either way, you'll have to go through the pharmaceutical assistance programs of some sort. GoodRx is one that somebody mentioned. I think it's been mentioned, previously.
Kathleen, is there an oral GLP-1 available already, a semaglutide?
Yep, oral semaglutide. Yeah, as of about a year ago, it was approved by the FDA. It just has taken a while to trickle into the formularies. So you probably don't see it used quite a bit.
Not on our formulary for some reason. So.
Mm-hmm. Yeah, you start off with, there's 3 doses, 3 milligrams, 7 milligrams, 14 milligrams. You, just titrate as tolerated. It does need to be taken on an empty stomach, 30 minutes at least, with 2 to 4 ounces of water. Okay. Could also reach out to YSU Dietetics program. Oh yeah, so dietetics interns. Let's see, did we cover your clinical questions?
I think so. Because like I said, I'm not sure if it's the injection itself or insulin. But just if anybody had any kind of catchphrases or anything, like I said, that they use when somebody is, so agreeable to monitor as frequently as he is.
Yeah, Karen, I didn't know if you wanted to jump in there. You're on mute. Okay,
Yeah,
there you go.
Just about to type something. You know, sometimes I'll, if I really feel like, insulin may be a good option for someone, I may talk about long acting because that's only one shot at night, and it just gives a trickle in of insulin, all throughout the day to kind of bring your numbers closer to target. And and insulin is terrifying. So there's really good reasons why people don't want to be on it. It's not just the needle; it's what it does when it goes in, and the risk for lows are higher. So I think acknowledging that there's you understand why they would have, who wants to have to do that, but there's maybe a safe way that you might consider that one, maybe one small injection could start at a small dose and see how it works for you. And if they feel like it's not for them, it's totally in their power to talk to the doctor about that and make another decision.
And do you think demos work? If you show them the teeny tiny size of the needles, have them look at, things like that, because they're smaller than your lancets even. So if you can do a finger stick.
Right. I mean, a lot of people, they're probably thinking of syringes and vials and long needles and those little tiny hash marks, and you can't see the numbers anyway. But when you show them a pen, and you can even just, they can hear the clicks. So if you have to do just 5 units, you can hear the click, 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 and then you show them the needle, and it's just it just looks manageable. I guess I could say that it's a lot more manageable.
So
Yeah,
this is Sharon. On really reluctant patients for insulin, I have given normal saline in the clinic, and they're amazed at how much they don't feel anything going into their belly. I mean, they feel the finger sticks, but there's not a lot of nerve endings in the belly. So it surprises them.
Mm-hmm. Yeah.
And even to the point, I'm not sure what his family members, what their picture of diabetes looked like. So they could have been the 3 to 4 times a day, required insulin injection. So that's a good point.
Okay. Well, we are at the top of the hour, so I'm going to turn it over to Shannon for our final wrap up. Thank you all for joining us for this Echo Clinic series. I had a wonderful time facilitating it, and hopefully you all learned a lot as well.
I agree. The past 12 weeks have flown by for us, certainly, and I hope you've enjoyed your time here, and it's been great to get to know you. So you can always register on our website to view all of the 12 weeks of this series. Next slide. And this is our accreditation statement for our CME office. Next slide. Today, you have received 2 surveys, a post-clinic survey and an exit survey. You have until tomorrow at 5 to do the post-clinic survey, and then you have until January 8th of next year to complete the exit survey. If you wish to claim CME credits, you will receive a separate email from myevaluations.com, and you'll need to register on that website to begin the CME process. And those surveys are also due in January 8th. And lastly, please remember that we are offering the same series again next spring. And Kathleen Dungan has agreed to come back and facilitate again. You can register on our website. It is a repeat of this series, so perhaps you have some colleagues that you would be able to share your positive experience and tell them to join next year. So you'll be getting some emails from me as some wrap up, and we have a contact list to share with you in case you'd like to reach out to anyone across Ohio, and we have some certificates for your participation as well. So it was great to see all of you. I hope you enjoy your day. Have a safe and happy holiday. Bye, everyone.